Buongiorno a tutti, benvenuti a Biennale Tecnologia, in particolare a questa sessione su salute e Big Data organizzata dall'Università degli Studi di Torino. Io sono Ciro Cattuto, sono un professore presso il Dipartimento di Informatica dell'Università di Torino e anche un coordinatore di ricerca presso la Fondazione ISI di Torino. Oggi ho il piacere di moderare questa sessione e l'onore di presentare tre veri pionieri che condivideranno il loro pensiero e le loro esperienze all'intersezione fra tecnologia e salute. In particolare oggi parleremo di tecnologie legate ai dati, all'intelligenza artificiale, alle piattaforme digitali, con applicazioni dirette alla salute sia individuale che pubblica. E naturalmente sarà impossibile, vi anticipo, non parlare della crisi attuale del coronavirus, perché si tratta di una crisi autenticamente complessa che stimola riflessioni molto profonde su opportunità, su sfide, su ostacoli da superare. Quindi sono molto onorato e molto contento di parlare di Big Data, scienza dei dati, intelligenza artificiale e salute oggi. E quello che faremo andando avanti è dividere la conversazione in tre contributi da parte dei tre pionieri ed esperti che abbiamo oggi con noi. Vedo con noi il professor I Brownstein, vedo con noi il professor Carmela Troncoso e il professor Vespignani purtroppo per un impegno dell'ultimo minuto non presente in collegamento, ma ci ha mandato un contributo registrato. E infatti suggerisco di partire con questo contributo registrato in modo tale che poi avremo il resto del tempo con gli altri due speaker con i quali potremo anche interagire sia fra noi che con il pubblico. Vado quindi a presentare il professor Alessandro Vespignani. Alessandro Vespignani è lo Sternberg Family Distinguished Professor di Fisica, Informatica e Scienze della Salute presso Northeastern University a Boston, dove dirige anche il Network Science Institute, l'istituto di scienza delle reti. È un esperto di fama mondiale di reti e sistemi complessi, sui quali ha pubblicato centinaia di lavori in tutte le riviste scientifiche dei campi rilevanti, fisica statistica, epidemiologia computazionale, ed è un pioniere nella predizione delle epidemie. È stato eletto Fellow della Società Americana di Fisica, membro dell'Accademia Europea. Nel 2017 è stato insignito del dottorato honoris causa all'Università Tecnica di Delft e nel 2018 ha ricevuto il premio Grant per i risultati su scienze della popolazione. È autore di molte monografie scientifiche, un libro sull'evoluzione della struttura di Internet, un libro sulla dinamica dei processi sulle reti complesse e un recente libro sul mappare le pandemie, pubblicato poco prima della crisi attuale. In italiano ha recentemente pubblicato un libro sulle previsioni e sui modelli matematici che si intitola L'algoritmo e l'oracolo ed è pubblicato ed edito da Il Saggiatore. Spero che insieme a me passerete un'interessante ora all'intersezione fra dati e salute e chiederei alla regia in questo momento di far partire il video del professor Vespignani. Grazie.
Thank you very much. I'm really glad to be here and participate to the Biennale and also honored to share the stage with a great panel. I apologize that I will not be in person at the question and answer time. Unfortunately, I'm I have to attend some meeting for the response to the pandemic, and I'm providing my speech in a recorded format. Let me share my screen. What I will talk about is how we can, through data, model and forecast epidemic in a completely novel and possibly unprecedented way. I always start by looking a little bit at this parallel between the numerical weather models and the numerical epidemic models. If you go through the history of the two fields, you will realize that while both of them are born in the 1920s, 1930, as a concept, the numerical weather prediction were operational since 1955. While if we think about infectious disease forecast and more specifically emerging health threats forecast, we have to get into 2015 to see some operational tests. So you see that there is a gap of almost 20 years. That is due to the difficulties in gathering the data that we need for the modeling and analysis of infectious disease. Why? Because the population, we as humans, we are involved. Our behavior is crucial in the way the epidemic spread in a population and spread across the world, and we need data that concern the social and aggregate, the society and our whereabouts. So this has all changed, and there has been a huge change in data availability in the last 20 years. This has been dubbed through the big data revolution, but as well in many other ways. And we collect data that goes from the human interactions and contact networks at the scale of single individuals, like the one collected by the social pattern experiment, who is led by Ciro Cattuto here in Turin. But as well, we have mobility across continents. We can harvest and data about commuting patterns. And as well, we have population data at unprecedented level of details and resolution. All that really has created a different armory of tools that we can use in the modeling of epidemics. And as well, we get novel digital data streams, another major revolution. So we have what we call active data collection, like participatory platform, like in Italy, InfluWeb, in which you can just submit regularly your symptoms, your information about possible flu infection, and these are active in the sense that you ask direct participations from users, but as well you have a lot of data coming from passive data collection. The fact that we send message on Twitter, on Facebook, that we search on search engines, and so on and so forth. So these are all data that are not meant to be used in public health, but provide really wonderful data sets and information that can be used in the public health process and modeling. This is really started a huge amount of innovation in what we call the digital epidemiology field, and my colleagues will talk about other aspects of it. But what is important if we think about modeling and the analysis projection of pandemic and epidemic patterns is that through those data we learn how to use surrogate signals. So for instance, the fact that we can use reservation system for restaurants and look at the cancellation, last minute cancellation of those reservations, and get a proxy and indicators for the flu season, as well as the use of multitude of signals to do all that. And also the fact that those data have brought in the field the full power of artificial intelligence and machine learning, that through the use of those proxy data can provide valuable information on the epidemic forecast. And if you want a proof of that, every year the Center for Disease Control has a flu challenge in which many of those models are used to make prediction on the flu season. Well, when we talk about COVID-19, however, we get into uncharted territory. We don't have training data. It's the first of a kind of a disease. The reporting and the data that we are dealing with are changing constantly in time. The testing volume, capacity, test type, the case definition, everything is really a moving target. In addition, most of the proxies that we use with novel digital data streams, for instance, are destroyed by the fact that we are implementing extreme, severe, and drastic non-pharmaceutical interventions that change our society and change our behavior. Well, that brings us to the fact that we need really to have actionable modeling, not just with new data, big or small, but with all possible kind of data. And the focus in the modeling is really the understanding of data sets in a scientific sense, so that through theory, in a way that we emphasize the interpretability, the understanding of uncertainty, the initial conditions, the prediction limits, we can provide intelligence on the course of the epidemic and the disease. Well, this is intelligence tools. In a sense, I always say that, you know, the doctors and the healthcare givers are the ones fighting in the trenches, risking their life, the disease. And in the case of COVID, this is really the case. What we do with those kind of approaches and data science and modeling is to provide a kind of intelligence. We try to anticipate the move of the enemy in order to administer resources, to take and prepare for contingency plans, and in a sense, you know, provide better tool to the fighters. Well, you know, models comes at this point in a wide range of shape and forms, and it depends a lot on what kind of geographical resolution you are looking at. You can go worldwide. If you're interested at the beginning of a pandemic to see what is the pandemic potential of a certain virus, you can zoom into specific countries or go down to the level of a single urban areas. And there are different methodology. Not always the more complex model is the best suited for certain answers, especially if you have data opacity. And so it's important to consider that models are based on a large volume of data, and generally those data are assimilated in different ways. Well, data are crucial in this part because, again, without data we could not imagine those kind of forecasting, analysis, projection approaches. We start in many cases with data which are very, very detailed, like the micro census data, in which there are data on hundreds of households and families, and then we, plug in those data also with the macro perspective. So, for instance, what is the age distribution of the country, the distribution of number of people in the household, so that we can recreate, in a way, synthetic populations where we have individuals and their contacts in different settings, like, for instance, the household, the school, the workplace, the community. We go down at the level of the single network that describe those interactions. And then you can also, coarse grain and get more approximate prediction or more approximate descriptions, like, you know, what is the probability that individuals of a certain age are in contact with individuals of a given age in different settings. And all that is depends on the kind of question you're asking to the model. And finally, well, you have always to integrate and assimilate those data in the infection transmission mechanism that are disease specific. There is no model that fits all diseases, and have to be fed with clinical data and the information about the disease. Well, we will talk, everybody's talking about forecast and projection, but actually its modeling is much more than forecast. It's, for instance, situational awareness. There are a few cases of a new disease in China. Actually, what is the size of the outbreak? We know that generally, especially at the early stage of an outbreak, we just intercept the tip of the iceberg. So can we use modeling to have some understanding of what is going on during the fog of war that we have during an outbreak? What is the intervention planning? So what we call scenarios analysis, so in which we assume that there will be certain interventions and we want to disentangle the effect of the intervention. This is really just providing a portfolio of possible futures that generally goes from the worst case scenario that is there to understand what is the risk that a certain disease poses to the society, then to the layering those interventions one by one and see what we can do, so that the policymakers have a portfolio of possible future and decide what to do depending not just on the modeling, but on many other information that are resources, logistics, policies, and so on and so forth. And then, there is also what we call counterfactual experiments, so the use of models to understand mechanism by really doing experiment in silico in the computers that could not be done in the real world. Well, you can imagine immediately what are the problems that we face with models. Models have assumptions, and there are uncertainties. Initial conditions are never known perfectly. Parameters, uncertainties, how long is the incubation of the disease, what is the transmissibility potential are known with uncertainties. And then there is the uncertainty, intrinsic stochasticity of the disease evolution. We have one pattern, but a few things might have led to a different patterns. When we are in a room with somebody, it's not deterministic that that person will be infected. There is a certain probability. And so what we have to do is that in the computers, we recreate all those possible trajectories, generate, in a sense, all the possible futures that are compatible with those uncertainties and assumptions, and generate a probabilistic outcome that will tell you, for instance, what is the importation probability of an infected individual from China, or at this stage, instead, how many people we might expect to be infected in the next week. Well, this is where the computational modeling becomes a computational problem, because that means that we have to run millions of simulations and millions of realization of those processes. And this is also a computational problem, not just a data assimilation problem. And through those, one of the tasks among the many, including the scenarios, the situational awareness, the computational experiment, is also the forecast. And forecast, we have to be very careful, because forecasts have to be handled on the short run. There is no models that can tell you why. In a sense, while scenarios can project 2 or 3 months in advance according to assumptions, well, forecasts are based on the evidence on the ground at a given moment, and generally they have some time horizon that is from 2 to 4 weeks, and they have generally a very important confidence interval that has to be considered in whatever analysis one does. This, for instance, is the deaths per week in the United States, and you see that data are used in the center part of this plot then to provide a cone of uncertainty for the future and the expected trajectory of the epidemic in the future. Well, here is where artificial intelligence and machine learning enters nowadays more and more into the novel methodologies, because in order to improve that confidence interval, in order to shrink as much as possible, machine learning is becoming one of the most important tools, not just so for the forecast, but also for merging what we call artificial intelligence methodologies, machine learning, neural networks, to improve also what the mechanistic models that I was showing before, in which you really simulate individuals and the transmission dynamics of the disease explicitly. Well, because you can augment, for instance, the ground truth of models. You can use machine intelligence to provide and disentangle the bias that you have in the data and in the modeling, because of the modeling assumptions. And you can also use simulations, mechanistic models in the machine learning as a data that actually used as an input to learn and improve the forecast. So you see, machine learning is becoming the frontier of the prediction of epidemics, and it's more and more used. Another things that really in 10 seconds I want to convey is the fact that it's important just not to rely on a single models, but actually to always use forecast and scenario analysis that include a portfolio of models, because each model will have its own bias as well, uncertainty as well as assumptions, and having more models that point out coherently to the same future generate predictions that are, and forecasts and analysis that are much more reliable. And indeed, this is something again that comes from our experience with weather forecast, where generally ensemble forecast, ensemble prediction are the state of the art. And so, for instance, with the Center for Disease Control, there is ongoing a very large effort that, how to say, ensemble more than a dozen models, and in producing forecast for the deaths and the number of cases in the US of COVID-19 in the next 4 weeks. Unfortunately, these are exercises and operational efforts that require infrastructures, funding, and a lot of teams. And at the moment, the Center for Disease Control exercise is the only one I know explicitly. Well, I think I can leave here, and my colleagues will touch on many other interesting aspects. I just want to close with this statement. You know, really, models are made to be unquestioned.
Credo che il video del professor Vespignani sia stato tagliato nell'ultimo mezzo minuto. In ogni caso ringraziamo il professor Vespignani per il contributo, che possa essere con noi, e ci scusiamo anche con l'audience per aver questa variazione. Adesso passiamo dalla scala globale della prospettiva planetaria, nazionale, regionale, sulla predizione di un fenomeno di salute pubblica come un'epidemia, alla scala di cosa possiamo fare a livello individuale, di quali tecnologie possono connettere i cittadini con un intervento di salute pubblica. E quindi andremo a parlare in particolare, e se ne è parlato tanto nelle news negli ultimi mesi, di tracciamento dei contatti, con una vera pioniera e un leader del campo. Abbiamo con noi la professoressa Carmela Troncoso. Carmela Troncoso è professore presso la Scuola Politecnica Federale di Losanna, in Svizzera, dove la sua ricerca si occupa principalmente di sicurezza e di privacy. Presso le PFL, il Politecnico Federale, Carmela Troncoso dirige il laboratorio Spring, il cui nome sta appunto ad indicare Security and Privacy Engineering Laboratory. La professoressa Troncoso si è formata in ingegneria delle comunicazioni presso l'Università di Vigo nel 2006 e poi ha conseguito un dottorato in ingegneria presso KU Leuven nel 2011. Ha passato del tempo come membro come faculty member, come professore e ricercatore presso l'Istituto di Ingegneria del Software IMDEA in Spagna, e ha anche collaborato con industrie e compagnie come per esempio Gradiant, presso cui era leader tecnico su sicurezza e privacy. La ricerca della professoressa Troncoso è stata premiata da diverse agenzie, riconosciuta internazionalmente in molti diversi contesti, a partire dalla sua tesi di dottorato, che è stata premiata dal Consorzio per la ricerca europea, dall'ERC, come migliore tesi di informatica. Nel 2017 ha vinto il Privacy Protection Award, il premio per la protezione della privacy, assegnato dal comitato CNIL dell'IRIA in Francia, e pubblica regolarmente nelle riviste e conferenze più prestigiose di sicurezza informatica, e recentemente la rivista Fortune ha nominato la professoressa Troncoso nella lista 40 sotto 40, 40 innovatori sotto i 40 anni, proprio per le tecnologie di tracciamento dei contatti che ora sono dietro la maggior parte delle app nazionali, inclusa l'app italiana Immuni. E quindi è un grande piacere cedere la parola alla professoressa Troncoso, che ci parlerà di tecnologie mobili e tecnologie che preservano la privacy mentre conseguono degli obiettivi di salute pubblica. Grazie.
Thank you very much, Ciro. Thank you very much for the invitation. Let me share my screen. So what I want to talk today about is, as Ciro said, the work that we have been doing in the last months regarding privacy-preserving contact tracing. And I'm not an epidemiologist, I'm a technologist, and I was faced with a problem that is that manual tracing, which is one of the main tools that we have to protect ourselves from epidemics, what allows us to break infection chains, was being overwhelmed by the volume of the speed of evolution of COVID-19 and SARS-CoV-2. So people thought that it could be good to have a technological complement that could help manual contact tracing. And the things that were needed is that this technology would allow us to contact people faster and to contact more people, including people that patients normally don't remember, or they just don't have the means to provide a contact for them, and do all of this in an efficient manner. This is, we were saying, one of the main problems is that the system based on humans that need to make interviews and call on the phone those that have been close to a COVID-19 positive person does not scale when we are at the heat of the waves. And one observation from this problem is that when we talk about contact tracing and we talk in the human world, we talk about we need to identify patients to be able to call them. Now, the very goal is not to identify the patients, is to call them. And that means that when we think from a technology perspective, what we need to build is a technology that allows us to notify users, not really to identify them. We don't want to know their names. We don't want to know where they are, just to be able to notify. And that was the problem that was posed to us. And with this came constraints, right? Every time we build something, we have some constraints. And a main constraint was, of course, the protection of health information. We're talking about very sensitive information that is very important for everyone, and no patients. The society is ready to just be revealing their health status to everyone. So we wanted to hide who are the positive users and also who are their contacts. And the second problem is that we were thinking about asking to put a technology on the phone of every citizen, not of the citizen of a country like Switzerland or Italy, but all of the users in Europe and eventually all of the users in the world. And as such, it's very important that this technology that we introduce does not introduce new problems, does not introduce the possibility for surveillance and for manipulation. And in particular, that meant that we needed to hide three kinds of information that can be used for this type of negative impacts, such as the user's identity, so who is sick, their location patterns, whether their habits, and their behavior, who they talk to, when they talk to these people, how often, what we call kind of the social graph. And of course, we want this technology, we want this in place, that it works. So it means that it doesn't raise false alarms and it has to be available. It should be difficult to do a denial of service on the system. And those were the kind of constraints that were important for social acceptability. But then for deployability, there were other hidden constraints that normally we don't think about. In particular, that we don't think about in academia, because in academia we just write on papers, and on a paper you can write anything you want. Now, when we want to deploy, things are very different. And the first kind of difference that we had with respect to academia is that we had to design under enormous time pressure. In academia, normally we think about the technology of the future, the technology that we're going to have in 3 to 5 years, and we try to be ahead. But here we needed a technology for a pandemic that is living with us, a technology that needs to be out yesterday. And in fact, in the first meeting where I was present, the deadline that we had was 3 weeks, 3 weeks for design, implementation, and deployment of this app. Of course, this didn't happen, but still the full process happened faster than anything that has been deployed before. And that meant that when we were designing this, we needed to follow what we call in security the KISS principle. KISS stands for keep it simple, stupid. And this is very important. It's a key principle of security engineering, because if we don't make things simple, it is very hard to analyze them and make sure that they are secure and they actually do what we think they are going to do. And again, when we're going to ask every citizen in the world to put this in their pockets, we needed to be absolutely sure that what we're implementing and what we are putting on the system is what we promise, right? So that we can really deliver what we said. And that's why we implemented something that couldn't have very new primitives, super fancy cryptography. We had to go for the very basics. Also, normally when we write on papers, you can write, oh, I'm going to have, a phone in the future that had new sensor, or I'm going to have this new device that everybody's going to have on their pocket. In reality, this could not happen in like 2-3 months that we had to deploy. So we had to use existing infrastructure. And everybody thought about the mobile phones, which is one of the most pervasive technology nowadays. Everybody has a mobile phone. I'm happy to discuss in the Q&A the impact of the technological divide. And therefore, we were limited to the capabilities of this platform, the sensors that they have, but also their battery life, their capability of connecting to the cloud, to connecting to the internet. And that meant that Bluetooth technology was chosen to be the technology to implement this kind of apps. And that meant that we were now constrained to what this technology can do. That means how much data they can transmit, how many times we can transmit, also given the limitations of the battery of the phone. And we needed to build with all of this. And I said many times, we need this to work for millions and millions of users. So that means that we need something that is highly reliable. And that means that we could not use kind of new technologies or technologies that are not typically mainstream, like anonymous communications or some of these new things that few use, but we don't know what would happen if we just throw all of the wall at them. So we had to deal with that. And solving all of this has been the biggest sprint that I have ever done in my academic or industrial life. We started in March, and by July, we were launching our first the Swiss app. I believe the Italian app was more or less launched at the same time. And since then, we have continued working on this topic to make sure that what we designed in the beginning, all of these privacy properties that we promised are still kept as the system evolves. And doing that required a very, very big team of people from different perspectives and from different disciplines to make sure that we would build something that actually works in the real world, but also gives the epidemiological needs, so the epidemiological functionalities that are needed to really help with the pandemic. So with all of this, when we had all of these constraints, I mean, it actually says like, good, cool, like very fast we came up with a design at the protocol level that was very simple and that gets us to the goal. And this is what you have in the Muni app, as Ciro was saying, is what is implemented in the Google and Apple API. That is what every app in the world, or almost every app in the world, uses nowadays. And what it does is that the phone will generate a set of random codes. These random codes are broadcasted all the time. They change over time so that they don't become an identifier. If people are close to another phone and hear these beacons, they will record it together with some information that allows them to estimate more or less how far they were. If you are too far, you will not listen, and then you will not keep them. Whenever someone is sick, what will happen is that they will receive a code. And with this code, they will upload the codes that they broadcasted. And this is the key design decision of the protocol. Why the codes that they broadcast? It is because those are the ones that do not provide any information. So allows us to hide all of this data that we want to not give out to prevent abuse. Because the random numbers are not associated to the identity. They are associated to a key that your phone creates totally at random. They are not associated to the locations or your behavior because they are generated according to a predefined schedule. And they don't have information about others because are just the ones that you broadcast. So these codes are put on a server that we call key server, and then all of the rest of the phones periodically go to this server, download all of these codes of people that are infected, and then look at internal lists. Have I seen before this number? If they have seen the numbers, they take the list of all of the numbers that they have seen, and they check with this power information whether in global they have been too close for too long to people that were positive, and in that case, they are shown a warning that tells them what to do. In the case of Switzerland, it tells them to call a landline. In the case of Italy, I'm not exactly sure what Immuni asks people to do. And this design ensures that no information is available for abuse. And also a second property that was also very important for acceptability by citizens, which is that many people were worried that we're going to put a technology in, and what if the government, once it puts it there, never removes it? But in this technology, the power to stop is on the side of the users. If the users never operate this anymore, so they decide to never move from 3 to 4, never to upload codes, the system dies because no more codes are going to be here. And it doesn't matter that phones continue downloading or that the government would still want to have things. The system just is not useful anymore. So kind of the power of plugging off the system still resides on the. But we soon discovered that actually the protocol was a very small piece in the puzzle. This was this crypto thing, very nice, very cute, but it actually doesn't solve the problem by itself. That's why the team grew during these 3 months to have more than 30 researchers from 10 different countries and from a lot of specialities. We had people from privacy, but also people that help us with the system to connect this to the cloud, cryptographers, wireless security. But we also had epidemiologists that help us really understand how the disease works, to make sure that every time we made a decision for privacy, we could not hurt functionality. We had ethicists, we had law experts that help us ensure that what we were designing could actually be usable in the real world. And from a technology perspective, it's also important to realize that the protocol needs to be supported by an app, that needs to be supported by a mobile operative system, that needs to then be connected to a health system. And each of these connections, when you put this piece of the puzzle here, needs also to many times also requires new privacy mechanisms or new redesigns of the system to make sure that, again, the properties that we promised in the beginning, this nobody's going to surveil you and this technology is not going to create new risks, is actually true. And this is what we did in the next 3 months after we proposed the protocol. And this is what I have been doing almost full-time and more than full-time since all of this started. We have invented a lot of privacy preserving mechanisms. We work very close with our developers. We work very close with the health system in Switzerland. And we also talk a lot with Google and Apple to make sure that all of these pieces of the puzzle don't break the privacy and the good properties of the system. So we have designed several mechanisms to upload keys that are privacy preserving, so that do not reveal that everybody that uploads is positive. We had to make different designs. Why? Because the system changed a bit in Switzerland due to how authentication mechanism had to be built to actually fit within the health system capabilities. We had to change it again because Google and Apple made decisions on the libraries without acknowledging that other people had to use these libraries in a bigger system. So we had to readapt our mechanism to take into account the changes that they proposed. We had to come up with privacy preserving mechanisms to retrieve configuration, because you know that we need to maybe update the thresholds to measure these distances. So we need a good way of going and uploading this as often as we need. But we need this to be without people revealing their identities, without them revealing that they are actually using the phone and a lot of those things. We developed mechanisms to count active users, which was very important to actually know how well are we doing in Switzerland, what is the percentage of the population that uses the app, not that downloads, but that uses the app every day without us knowing who they are or where they are. We decided at some point that the app would show more information to the users so that it could be more useful to them. So it shows them how many cases there are and what is the app usage. To do this, it has to, again, download information. We had to design new ways of downloading this information to make sure that we don't leak more information. And now when it comes to time where apps from different countries connect to each other, we have to, again, redesign different parts of the system to make sure that these new downloads and these new exchanges of information do not affect users' privacy, do not reveal whether they travel, do not reveal where they travel, and a lot of other things. Right now in Switzerland, we have 1.88 million active users. I think right now it's actually 1.89. that is roughly 22% of the population. In the month of Switzerland, where in the month of October, when were in the heat of the second wave, we have more than 15,000 users uploading their keys. That's 15% of the PCR in Switzerland, and this is a worse result than before. Would we
Sì, ci sono.
see that we have less than the number of active users? And in the field, we have
Sì, ne sono 18 minuti.
Should I finish, Ciro?
Prenderò solamente una domanda alla fine, se c'è tempo, altrimenti chiudiamo.
So we have very good results in the field,
sì.
where we see that actually the app helps with the speed. Indeed, we have faster notification, and we have in Zurich, in a very cohesive cohort, that for every code we have 22 contacts, and many of them are sent to quarantine, and 1 of every 10 cases that go to test for the app are positive, which means that we are actually busting a lot of infection chains. So this is the first privacy by design product that has been developed at large scale, is by now in many of these places. These 5 countries, 6, actually use our code base and use a lot of the mechanisms that we designed to give privacy to the whole course. And the key lessons we learn is that integrating in the health system is hard, but it is key for the system to work. And that in a real world, privacy engineering is much more difficult than in academia. And finally, this is not over. We're currently working on an extension of this kind of apps to do presence tracing, so to be able to notify people that were at a location, like at a bar or at a club, where there was a positive. And today we have released the first prototype of an app that does this. Please go check it and give us comments, because maybe we just need this technology to actually be able to beat the pandemic. Thank you very much.
Thank you very much, Carmela. This is great. And now we basically, to a third perspective, we started by looking at innovative uses of data, like Professor Vespignani showed us, and then we went to innovative uses of our personal devices, with the specific case of contact tracing. E adesso passiamo, scusate, parlavo inglese, e adesso passiamo al terzo ospite di questo panel, che è il professor John Brownstein. È un enorme piacere avere qui John Brownstein, perché John Brownstein è davvero un pioniere nell'uso innovativo di dati e tecnologie per la salute. John Brownstein è il Chief Innovation Officer del Boston Children's Hospital a Boston, negli Stati Uniti, l'ospedale più prominente, l'ospedale pediatrico più prominente del paese. È professore di pediatria e informatica biomedica presso la Harvard Medical School, la scuola medica dell'Università di Harvard. Dirige il laboratorio di pediatria computazionale presso il programma di informatica del Boston Children's Hospital. Tutta la sua attività di ricerca si è concentrata su sorveglianza, controllo, prevenzione delle malattie. Il suo background è in epidemiologia presso l'Università di Yale, e poi ha fornito contributi pionieristici alla salute digitale, come il sistema HealthMap, che sono stati utilizzati da molte agenzie di protezione della salute, dall'OMS, dal Center for Disease Control e da milioni di utenti ogni anno. Ha ricevuto molti premi, in particolare ha ricevuto il prestigiosissimo Presidential Early Career Award, il premio presidenziale alla carriera per scienziati ed ingegneri, che è il più alto onore che si può ricevere negli Stati Uniti per la ricerca. Ha ricevuto qui a Torino anche il premio Lagrange nel 2016, assegnato da Fondazione Easy per la scienza della complessità. È un advisor per Uber e Google in materie di salute, e ha anche fondato start-up e compagnie come Epidemico, Circulation e molte di più. È autore di oltre 250 articoli nei più prestigiosi giornali di salute, pubblica e medicina, e quindi è un grande onore e piacere dare la parola al professor John Brownstein, che ci parla di uso innovativo di dati e tecnologie. John, the floor is yours.
Okay, wonderful. Can you hear me? Yes. Okay. Thank you so much, Ciro, and it's great to talk and to round out this amazing panel. 2 great talks so far, so I'll try to go a little bit fast here to tell you a little bit about how we're approaching this pandemic in the broader field of digital epidemiology. Alessandro, spoke a little bit about some of the opportunities around data and thinking about how we use new data streams to inform pandemics. This is a report that we got on December 30th from our technology health map that identified a mysterious outbreak that was taking place in Wuhan that clearly we know now to have been the pandemic and COVID. The reality is being able to collect data at a global scale in real time at a high resolution to be able to understand what is happening on the ground, to inform policy, inform interventions, is something that is very challenging for pandemics for many years. Clearly now, with the world focused on this pandemic, we have lots of new opportunities to think about how we rethink data as it relates to tracking emerging infectious disease. But just before I get to the COVID, I wanted to explain the challenges of traditional data when we think about emerging diseases. People get sick, they're seen by healthcare providers, that data gets validated by laboratories and ends up to WHO. But each one of those steps can take days or weeks. And this is why we think about new data sources like digital epidemiology, and I'll explain what that means, that allows for everyone to have access to information simultaneously. This is very similar to how we think about the weather and climate. Data is made available by government agencies through APIs that then essentially create an ecosystem of applications that allow us to know what's happening at any given moment with temperature and climate, but also allows us to build forecasts. The problem with public health is that we're missing all of those elements. We don't have underlying data, there are no APIs to that information, and there's no essentially ecosystem of applications that really allows us to know what's happening on the ground. This is why we've turned to the field of digital epidemiology, the idea that we could take the digital exhaust, the data that people generate in their daily lives, whether it's through searches online, through social media, through devices. Some portion of all of those interactions are health-related, health behaviors or outcomes. And if we can do this at scale, looking through many different individuals, we can actually get real meaningful health insights, whether that's emerging infectious disease, chronic conditions, health behaviors, especially behaviors that we can't track through traditional sources. So the reality is, with these kind of infos, big tech companies have access to global information in real time about individuals. And how do we harness that information, not just for advertising, which of course is what is used, but how do we utilize this information to get deep insights into health? This is part of a technology that we developed called Health Map, but there are many others, and in the EU there's many other tools and efforts that are ongoing. But our view has been, how do you tap into all the online intelligence across the web through multiple languages to get about disease events in a rapid every hour sense? And the way that we do this, and I won't get it, so we have very limited time, but we use natural language processing to classify articles, extract important content, and then filter the noise through a machine learning tool. So essentially getting deep access to all that insight, but organizing it in a way that people can essentially tap into it. So an outbreak takes place, we can parse out the location, the event, the numbers of cases, and build a living, breathing map of emerging infectious diseases. This is Health Map, and this has been operating now for over 15 years and is generating information that pushes data to the WHO and ministries of health and makes it widely available and open to the public. We, of course, were heavily focused on COVID as the events were emerging, but we also recognized that there was a lot more that could be done beyond just the data sets that we were collecting. I'll just mention a couple different efforts. One was about trying to identify early insights about COVID as it was emerging in Wuhan. We started tapping into previous studies that we have done, one using satellite images, so digital data about cars in parking lots of hospitals to look at how busy these hospitals were as a measure of social disruption. We've done this to track flu in Latin America, and then also looking at search query data from the search engine Baidu. And amazingly enough, what we saw is that hospitals started getting busy in early fall. And again, this doesn't prove that COVID was emerging early, but essentially points to the fact that there was initial data sets that were giving us these early signs of something happening. The bottom panel shows the Wuhan seafood market and essentially how after lockdowns, no cars were parked at this market. When we start looking at this in combination between multiple hospitals and then also search query data, for symptoms like cough and diarrhea, we start to see the emergence potentially in the fall of this virus ahead of some of the clinical data sets that were only sort of made available at the end of December and mostly really in January. The reality is that our focus has been really deeply about open data for pandemics. This was a paper that we published at the beginning of the pandemic about epidemiological data and the need for rapid communication of detailed demographic and case information, geographic data that could help inform the response. We launched an initiative called global.health, which was all about thinking about what's the next version of how we operate in making epidemic data available, not just about events, but how do we make case information provide detailed insights. And we partnered with Google, Oxford University, Georgetown, Northeastern, and Johns Hopkins to create this new paradigm when it comes to open data, when it comes to pandemics. We built a curator portal, started pulling in data sets from across different sources, ministries of health and other official reporting, started parsing this data through automatic extraction, data cleaning, and essentially have created now a portal to provide open source information to the community. And so this is what is really exciting from our perspective, because now not only are we able to use this data as information that help rapid interventions when it comes to response is for pandemics. And this is just a view of the beta site that we're launching in the next couple months. The data in itself quickly used to help inform policy. For instance, this is a paper we published in Science showing that using this detailed demographic data plus movement information from Baidu, we could actually show that the impact of lockdowns worked. And clearly at the beginning, we weren't clear that lockdowns would actually help limit transmission. And we started about other ways to collect data. This was a paper we published in the New England Journal of Medicine that was talking about the opportunities around surveying the crowd for symptoms of COVID. And so we started building a tool. This is COVID Near You, which is extracting people's symptoms and capturing millions of people on the site, just telling us how they were feeling and what tests they received for COVID. That data in itself has been incredibly valuable for surveillance purposes, especially when testing was limited. But we also started expanding into understanding, for instance, mask wearing. We collected close to 400,000 responses about people's mask wearing behavior. And from actually show if we increase mask wearing in a population, we could start to drive transmission down directly in a community. So community took on mask wearing, over 50% could bring transmission down below 1. And we could also start using data that we were collecting to understand disparities. So what is the time to the nearest testing center, right? The challenges of access to testing are so important to being able to intervene in the pandemic. And the reality found is that access to testing for COVID was directly related to disparities. So those that are underprivileged minorities, those that didn't have access to healthcare were the ones that are left behind. And those are the ones that are highest risk of complications from COVID. Now, a big part of what our team is working on now is building technology for the US government around vaccine availability. And our role has been to think about how to make consumers aware of what vaccine will be available for them for COVID. This is a project actually we took over from Google years ago called Vaccine Finder. And now we're adapting it for COVID with the idea that any individual who wants a COVID vaccine can come to our site, figure out their eligibility, and working with all the providers in the country, we'll be able to give them insights into when and where they can get this vaccine. So working with CDC to ingest every single pharmacy and provider and essentially make this a living, breathing map that essentially everyone has access to and try to reduce the disparities in access to vaccines. I'll just mention that another element, and again, this is a rapid talk, but another element of digital epidemiology is understanding vaccine hesitancy and rumors when it comes to COVID vaccines, but also any immunizations. And even though we're going to have potentially a safe, effective vaccine, people are still going to be hesitant about getting this vaccine. In the US, about half the population will not be ready or want to get this vaccine as soon as it's made available. And so we have a real challenge in the US, but I think across the entire globe, of convincing people that the vaccine is safe and effective. And if we don't do that, clearly we're going to have struggles in terms of getting enough people immunized for this vaccine to actually have the effect around herd immunity. So I know I've gone very quickly, and I know you have a hard stop in a few minutes, but at least it gives you a general sense of what we're trying to do when it comes to new data sets that can feed into the models that my other panelists have been talking about. So thank you so much for your time.
Thank you very much, John, and thanks to all the panelists here. It is great to see this group together. And I think we have time for just a couple of questions. I don't know how the system works. It's the first time I use the system, so I wonder if credo che abbiamo tempo per delle domande. Non so se la regia può selezionare delle domande o quale sia il meccanismo. Dunque, mi dicono che ci dovrebbe essere una chat su cui io però non ho ricevuto istruzioni. E farò io allora una domanda agli speaker. Carmela, John, since we only have a couple of minutes and many of the people in the audience are actually students. This event is organized by the University of Torino within a larger event organized by the Polytechnic University of Torino. Would you say, like, what would you say 30 seconds to a group of young students who are interested in, exploring this space? And Carmela, do you take this? Or either of you? I mean, just...
what I would say is there is a lot of things to do, and we need a lot of manpower. So many ideas, like it's hard to find, it is easy to find ideas to work on. And that what I would also say, like from my perspective, that they should try to think out of the box about other ways of solving problems that may be less invasive, even if we use technology, than some of the solutions we have nowadays.
Listen, I think that my view on this is we've for many years struggled to get people to get excited about public health. And it's amazing to see that the world is, focused on emerging infectious disease. I mean, sure, you and I have been working on this for a very long time, but we haven't seen a lot of innovation and excitement. Now it's all happening. It's a great moment for people to get into this field. My only hope is that, people will stay in it, right? Like if you want to invest for the long run, in education and think about opportunities to bring new technologies, new partners together. My hope is that people will not just walk away from, this because now COVID in a year is not exciting anymore. We're going to have another pandemic. We're going to have other major events. We've had many for so many years. So hopefully this is a starting point for people to actually build sustainable technology that will, have long-term impact.
Thank you very much, John. And I think it's time to wrap up. So let me thank again Professors Carmela Troncoso, John Brownstein, and Alessandro Vespignani, and the organizers of Biennale Tecnologia from the Polytechnic of Torino. Grazie a tutti e buona giornata.
Thank you.